the tricks of the. So let's start from there. So how I was told was that there'll be three case scenarios, and then we'll go over each case presentation, and one of the senior residents from one of the programs or anybody who wants to answer will take the whole case. Is that correct?
Yes, Dr. Shah. So that's how we had planned for how the sessions would go for this exam prep.
Right.
Exactly what you mentioned, that one case, one's chief resident would answer all the questions, and then you can give the feedback of how to approach those particular scenarios, give some tips and tricks, what examiners are looking for, and what best the candidate can do.
Right. Okay. So uh, who wants to take the first? Let's do this one. Uh, this will be recorded, but let's okay. Okay, so this is case one, and what you see here is this. Um, you want to read, or I can read that out as well. Who's taking the question?
Like any volunteers from the chief residence, that would be great. Like,
Let's start with Jihoon.
Yeah, sure, I can go.
Yeah, good. So, Jihoon, you're called into the ER to assess a 45-year-old female presenting with facial trauma following assault with a weapon. She is
Mhm.
vitally stable, clear trauma to frontal region, eyes are open, um, to verbal command, able to speak and confuse sentences, and able to squeeze fingers on command. Both pupils reacted to light, stream of clear fluid running from the nose. What is this patient's GCS?
I'm gonna need a second to
Oh,
calculate
sure,
that.
absolutely. People there, you have time for that.
Sorry.
You will have time for that.
Okay, sounds good. Give me 1 second. So I to verbal is 3. Confused is um so uh, is 3, and on command is
Three or four?
5. Or
Sorry
sorry,
about that.
confused. 1 sec. I might have to review this again, but yeah, it's for confused sentences, it is they're coherent, then they're oh yeah, confused.
I had that at setting
Um
15 meeting.
yes, it's 4. And then for squeeze command is 5. So it'd be 3, 9,
Five or
12.
six?
Command I thought was
Squeeze
sorry.
on command.
Okay, must be 6 then. I'm gonna have to review it.
Oh, that's okay. That's fine. So the GCS is in total of
13.
13. Good. All right. That's nice. What do you see here? And what is it called?
Halo sign, and so CSF leak is high on my differential.
Why does this appear like that?
Because CSF fluid does not coagulate while blood does.
Okay. Any other reason?
Um, I'm not sure.
Less protein diffuses out, right? In the
Mm.
blood. Okay. Uh, Name a few ways to test CSF leak.
So yeah, there's you can do the halo sign. You can also do the tram track sign.
What's a
Uh,
contact sign? Where do you see that?
so if it's coming out and then you see the CSF fluid on the sides and then the blood in the middle.
It is also known
Uh,
it is also known as tramline signs.
Tramline sign. And then you can also do blood testing, so beta transferrin, as well as you can assess like the content, like you mentioned, for levels of protein and
Can you
glucose.
elaborate a little bit more on the contents?
Yeah, so um, glucose, sorry, protein is lower
Mm.
on CSF. And then there's also, I think yeah, sorry. I am not confident enough to
There's
I'll have to review that.
chloride, there's potassium concentrations, and lower glucose. Okay, high
Yes.
chloride, and lower potassium, and lower glucose counts. Anything clinically that you can do for these patients? I mean, this is the laboratory tests. I mean, it takes a while. But what can you see clinically apart from this halo sign? What can you do at this on the bedside?
So other than halo sign and the tram track or
Yeah,
tram line, um,
on the bedside. You've gone to see the patient, but you want to be more sure about it, right? What can you do?
mhm. Mm, to be honest, those are the only tests that I'm aware of. I'm not sure if there's another.
We'll ask the patient to sit up and then do a Valsalva maneuver, right? He's probably pouring out of this.
Oh, okay.
That's
Valsalva.
right. What imaging do you order now here?
I
And
would want to. Oh,
just one
sorry.
question, how long does beta transferrin takes?
It takes hours.
Uh,
Um, mhm.
Maybe several days, perhaps.
Oh, several days. Okay.
So it's not an instant information you get. What imaging would you want to order?
So start with the CT facial.
CT facial bones, okay.
Hmm.
What tools would you use to assess the need of a C-spine injury?
So C-spine, you would have a mix of a CT as well as clinical exam, and then potentially, if indicated, you could get an MRI.
Are you familiar with any screening decision protocols?
Yeah, CT, yeah, C-spine, Canadian C-spine rules.
Okay, good. That's good. All
Mhm.
right, that's nice. Let's go from this. Describe this fracture pattern.
So I'm looking at a
Before, before,
coronal, I guess.
before we actually
Sorry.
go on to this subject, describe the management of CSF leak. Let's do that.
Managing a CSF leak. So it depends on, I guess, the extent of CSF leak and other injuries associated. So there's non-surgical management techniques as well as surgical management techniques that you can do. So while you're waiting to get more information, you would do the non-surgical techniques first, which would include sinus precautions and decreasing intracranial pressure and preventing increase in intracranial pressure. Did you want me to go further into details about that? Sorry?
Yes, please.
Okay. So yeah, sinus precautions, not blowing nose, sneeze with mouth open, and trying to in terms of preventing pressure to the head, um, you want to have the head elevated. You can do other things like mannitol if you wanted to. You could have them hyper ventilate. You could have them have mannitol, hyperventilate, oh, hypersaline solution. I think those are kind of the things I would start off with first.
Giving antibiotics to this patient.
Yes, and antibiotics as well.
And what are those antibiotics and what are they acting against?
Yeah, so you'd want to, I think this is a bit controversial, but
But if
you,
you ask what antibiotics would you prescribe?
yeah, so I'd recommend 2 grams of ceftriaxone. Um, and that's gonna be Q12 as a meningitic prevention dose, as well as vancomycin um, for pseudomo. Yeah, I think it was no, vancomycin. So the bugs you're trying to, it's oh, one sec.
Streptococcus pneumoniae,
Yeah, strep pneumoniae, and then there's one other one.
Neisseria meningitis.
Yes, Neisseria meningitis. Yes.
Mhm.
So then that and vancomycin.
Describe this pattern. Fracture pattern.
So CT, facial 3D recon, looking at it from like a coronal aspect. But basically you see so from the top to bottom a frontal sinus fracture involving at least the anterior table, unable to discern posterior table involvement. There's displacement um, as well as a NOE pattern appears to be Markowitz type 1. And then moving down, there's a left parasymphysis involving inferior border that's comminuted, extending posteriorly towards the body and angle. Um, and then from this view, those are the only fractures that I can see.
How do you classify NOE fractures?
So yeah, Markowitz, there's type 1, 2, 3.
And how do they differ?
So type 1 is when the medial canthal tendon is attached to one segment, it's not comminuted. Type 2 is when it is comminuted but it's still attached to a segment, and type 3 is avulsed.
Okay. What information would you want to know regarding the frontal sinus fracture here?
Yeah, so for frontal sinus fracture, I'd want to look at the other views to see which aspects are involved, specifically the anterior table, posterior table, and the frontal sinus outflow tract. And so those are things that would indicate whether or not, um, what type of procedure is required.
Good. That's nice. Good. Let's move forward. This is a different patient, but we just brought it in for you. Patient undergoes a decrease in loss of conscious and is admitted to ICU where she is intubated. There is a small intracranial hemorrhage. What is this intracranial bleed?
So this is
What,
sorry?
what do you see on this axial view?
Yeah, basically I'm seeing an intracranial hemorrhage, which is kind of lens shaped-ish, which is a epidural hematoma.
Oh, epidural or it's a subdural? It's
Uh,
hmm,
it looks not epidural, because subdural would be subarachnoid. Oh my gosh. Um,
how does it differ?
yeah, so epidural is
What,
above the dural, subdural is below dural, and then there's subarachnoid.
which is
Um,
more emergency treatment?
sorry?
Which is more of an emergent situation?
The epidural.
Epidural, that's good. Okay.
Mm-hmm.
This is subdural.
Subdural, okay.
All right. That's give me the layers of tissues overlying the brain.
So there is the um meningeal layer, there's the arachnoid and the pia.
Okay. And the periosteal later as well on that. Describe
Yeah.
Monroe-Kelly doctrine.
Oh my gosh, this is going back.
Oh.
Let's see if I can pull this out from my brain. This is about the pressure and like a
It's the
I would
inter
not be able to confidently tell you the right answer.
constants are constant, right? So pressure increase has to go somewhere.
Yes.
Right? Do you know what's the normal ICP pressure is?
ICP is less than or like less than 15.
Okay.
Mhm.
All right. Now, how do we actually, let's go further. These are the scans for these patients, for the same patient that we talked about.
Mm-hmm.
Have a look at it. That's the axial view.
Okay.
Look at the fractures there.
Yep.
Okay. And then I'll play the other one as well. Okay. See this one too?
Oh, sorry, the other one's still going. But you just want me to focus on the frontal sinus?
Yeah, well, whatever the fractures are,
One sec.
it's the same patient basically.
Yeah. Okay. Sounds good.
All right, so now the patient was stable,
Mm-hmm.
gone to the ICU, and now the ICU people want you to take the lead and plan the treatment.
Mm-hmm.
So what will be your treatment algorithm for frontal sinus trauma? And what are the teams you would want involved in this case based on your
Yeah, so in terms of treatment algorithm, I kind of mentioned previously it involves which aspects are involved. So anterior table, posterior table, and the frontal sinus outflow tract. In this,
there's a posterior table fracture as well.
sorry?
Assume there is a posterior table fracture as well.
Yeah, there was, I thought I saw, but so basically, I'd first want to get based on this finding, I'd want to get neurosurgery involved because this patient has an anterior table, posterior table, and what it looked like on that quick video involvement of the frontal outflow tract, which with posterior table involvement, I guess that's less of
Mhm.
um, a thing. But basically, neurosurgery would be involved because we would want to do cranialization of the frontal sinus.
Mhm. And what we do with the science itself?
So cranialization involves obliteration as well.
So what, give me the steps. How would you do an obliteration?
Yeah, so basically, you would map out what the where the frontal sinus is. You would take off the front anterior table. Then you would remove all the sinus lining, and then make sure that, well, neurosurgery would then approach the posterior table to take out all the fractured components, do their cranialization, and then obliteration would consist of either like putting like bony fragments or some sort of blockage. So you can do like muscle to obliterate, fat to obliterate, or like a periosteal flap to um, basically occlude the frontal sinus outflow tract. And then with that, you would now repair the anterior table and close.
How would you assess the patency of nasofrontal outflow tracts?
So you can use propofol or other colored liquids to assess, or you could try endoscopically as well.
How would you treat a patient who has got unilateral obstruction of nasofrontal outflow tracts and you don't have a posterior wall fracture, it's just the anterior wall fracture?
And it's unilateral.
Yes, unilateral. The other is patent.
Hmm.
You want to
Well, like I previously mentioned, you could potentially get your ENT colleagues to do an endoscopic repair of the frontal sinus outflow tract.
what else can be done?
You could, if the anterior table is fractured,
I
remove that aspect. Sorry?
assume that ENT colleagues are not available.
Then you could take off the anterior table and then do basically just an obliteration if the posterior table is not involved. Um,
What else you can do? I mean, you have one patent side of the frontonasal duct outflow, nasal frontal outflow. One is patent.
are both sides connected?
Well, you can make them connected. How?
Yeah. So, mm.
An answer. Anybody from the audience?
I think maybe what you're asking, Dr. Shah, is you could like remove the septum if there is one to allow for drainage to the other side.
Okay.
You can trim it down. Absolutely, you can trim it down. All right. Now, how would you surgically approach this patient? Would you do the mandible first or the frontal bone first?
I feel like for this case, they're pretty separate. And so I don't think it would be wrong to do either.
Yeah.
Um, yeah. But I guess I would do from top to bottom, because you're going from more sterile to unsterile by doing so.
So, what are the early complications of sinus obliteration or crenalization?
Sorry, say that again.
The early complications of frontal sinus obliteration and crenalization.
Yeah, so early would be infection, specifically meningitis, as well as um,
Very simple ones first.
yeah, like bleeding, um, increased intracranial pressure.
That will lead
Uh,
to
sorry, that could lead to.
V2.
Sorry, I can't hear you.
CSF leak as well.
Yes, CSF leak,
Yeah.
persistent CSF leak, and then yeah, meningitis.
And what are the late complications?
Late complications, um, there could be a aesthetic defect. There's, well, you can get meningitis still, mucocele,
Mucopyoseal. Yeah.
mhm, and
Brain,
then
brain abscess.
brain abscess, yep,
What else can
and
happen?
pyema.
We've done some surgical procedure on this. Osteomyelitis can happen also,
Yes.
right? Can happen too.
Hmm.
How would you, what is your comment here? Should we extubate this patient or should we have
Mm.
something else instead of keeping a tube in there for a longer period of time?
Yeah, I guess it depends on what the indications, like there's different indications for keeping a patient intubated, but if they're going to be intubated for a longer period of time, then that would be transitioned to a trach.
Okay, that's a good answer. What would be your protocol to follow up? And this is how we did it, just to show. This is
Mhm.
Manitoba. Um, what would be your protocol to follow up and follow up a frontal sinus fracture that has been treated either by obliteration or by crenalization?
So you would want to do more frequent follow-ups in the initial post-operative period to catch for the early signs. So usually the protocol we follow is 1 week, then 2 weeks, then 4 weeks, then 6 weeks for the initial post-operative period. Then we would move on to 3 months, 6 months, 12 months. And then from that, for frontal sinus fractures, we'd want to do prolonged follow-up up to and more than 5 years is what is in the literature,
Right.
because there can be delayed like uh,
And how many times would you image this patient?
complications. Sorry, imaging. You'd want to do it yearly.
Yeah. Good. Thank you very much. That's all for this case. It was good, but I think you need to go back some of the basics stuff that
I
you,
do.
but that's fine. I mean, they can move you around these trauma cases, right? So,
Hmm.
but I think I would say a good 70% was there.
Thank you. Yeah, the
And
always forget this GCS status, and every time I review it, I'm like, I know it, and then the next month it's gone.
we will not miss this. They will certainly ask you this question, right? Okay, thank you very much, Gio. All good.
Thank you.
Dr. Shah, if I can just quickly interject, I just wanted to just let you guys know that for chiefs who are answering, if you guys need to phone a friend for any reason, you're more than welcome to do that.
Say it again.
I'm saying if the chief who's answering the question may not know the answer, or if they're struggling with it and they need to phone a friend,
Okay, to
but
find an answer. Oh, okay,
yeah,
that's
yeah, yeah.
you guys can also speak up. I mean, that's not a problem. They don't have to call in a phone. Somebody can speak from here. Okay, who's number two then?
Are there any other Chiefs here, Amber? I can go. I helped make some of the questions, but not this one, so I don't know this one.
If
So
there's nobody there, then probably we could do that.
Sure,
Go,
I can do this one. Yeah.
go for it. Go for it, Derek.
Okay, so you're called to assess a 36-year-old male in the ED with significant left orbital edema and proptosis post blunt trauma. There's no other injuries. He's reportedly otherwise healthy, no allergies, and he's vitally stable.
I would just want to add one thing: left orbital edema, pain, and proptosis.
Okay.
All right. How would you perform your clinical examination, Derek, here?
Yeah, so I would start by um, seeing the patient. I assume obviously his primary survey is done and he's vitally stable. At this point, we can move on to the secondary survey. So our role would be a full head and neck exam, starting with a general inspection, looking for any lacerations, abrasions, edema. Obviously, it notes he has significant proptosis, so I'm going to be focusing my exam on a visual acuity exam, extraocular movements, proptosis, pupillary exam. I would also continue with a full cranial nerve exam, depending on the severity of what I'm finding. Examining for clinical evidence of facial bone fractures, crepitation over any of the facial bones, bimanular palpation of the maxilla, assessing his occlusion, looking for any step deformities in the mandible.
Mhm.
Are there any pertinent findings from that?
Yeah, how would you look at the intraocular pressure? And what's the normal intraocular pressure?
Yeah, so I would first do a clinical exam. So check his visual acuity, check extraocular movements. It sounds like he has proptosis. I feel like I know where we're going here. So I would probably get a tone pen and check intraocular pressures with that. So with the patient sitting up, I'd probably give him some tetracaine eye drops to allow for him to be comfortable and not moving. I would have an assistant gently retract the upper and lower lids without putting too much pressure on the globe.
And then how do you retract that? What do you retract with your fingers or use
Yeah,
some?
probably just with two cotton tip applicators very gently, so I'm not pushing on the globe and distorting the measurements. And then normal pressures are usually below 20 for a patient without glaucoma. Yeah.
So this patient has an RAPD. Briefly describe the pathophysiology of RAPD.
Um, okay. Yeah. So RAPD, so relative afferent pupillary defect. So it's a damage to the afferent pathway. So damage to the optic nerve. So I would do a swinging light test. And essentially, what you would see is if you shine light in the affected eye, so the eye in question, you would see no response. If you shine light in the unaffected eye, you would see a pupillary constriction of both the unaffected and the affected eye due to the crossing of the optic nerve in the Edinger-Westphal nucleus.
Okay,
If that makes
that's
sense. Yeah.
yeah. Thank you. But this is an important question for all of you, right? You must remember that. What do you see here?
So here I see a CT scan. The large image is an axial slice. You can see the left eye is clearly proptotic with some buildup of looks like blood behind the globe. I can't really discern the optic nerve, but this is clearly a retrobulbar hematoma.
Mhm.
On the coronal aspect, I can see what looks like a small medial wall fracture and orbital floor fracture, no significant hemosinus. And then on the sagittal view, you can see a very minimally displaced orbital floor fracture with a little bit of blood pooling at the back of the sinus. Patient was obviously laying down for the scan.
So, given this patient has an RAPD, painful proptotic eye, with a new loss of visual acuity in the left eye, what would be your management in this case?
So the patient has a loss of visual acuity. And what are the intraocular pressures?
They're high, 40.
Yeah, so it's a clear indication for an immediate lateral canthotomy with cantholysis.
How do you do that?
I would bring the patient into the resuscitation bay, have him consciously sedated by the emergency room team and nursing. I would first inject local with epinephrine down to the lateral orbital rim. I would then clamp the lateral canthus for 2 or 3 minutes. This might help with hemostasis. I would then take sharp tenotomy scissors and perform a lateral canthotomy as deep as possible down to the lateral rim. Once that's complete, I would try to identify the inferior limb of the lateral canthus and perform a cantholysis, making sure there's good lid laxity of the lower lid. And then I would repeat my intraocular pressure measurements and confirm a decrease. I would want them to be at least below 30 after this.
Yeah, that's right. So what is the window of time before you expect permanent vision loss?
Um, yeah, I've seen variable. I think you can have some degree of damage even within like an hour of onset of loss of visual acuity.
Average.
Yeah, and then complete loss, I think if the pressures are elevated with loss of visual acuity for like 8 hours, it would be expected not to have any return of visual acuity.
Within a couple of hours, right?
Couple of hours, okay.
2 hours most important. Are there some medical options too, in addition to canthelysis?
Yep, yep. So there's several medications you can give to decrease intraocular pressures. Like alpha and beta blocker eye drops. So like a timolol eye drop should be administered. This patient should receive high dose steroids. So, at least 250 or even 500 of solumedrol should be administered as soon as possible. And then you can also give them um, mannitol
Yeah.
or osmotic diuresis to decrease intraocular pressures. And then acetazolamide, which is a carbonic anhydrase inhibitor, is also indicated in this situation.
That's great. Now you've done your canthelysis, patient's intraocular pressures come down to a reasonable limit. What general orders would you write for the nurse?
Um, yeah, so I would say head of bed elevation, at least 45 degrees. I would say visual acuity checks Q1H, and then I would probably come back myself, Q2H to repeat the intraocular pressures. And then the medications as discussed, I would also order.
All right. That's good. What do you see here?
Yeah, so this might have been the patient from the question. You can see this 26-year-old male with clear facial trauma to the orbital region bilaterally. He has several small abrasions with some dried blood around. He has significant subconjunctival hemorrhage of both eyes and significant chemosis of the left eye, the eye in question. From this image, I can't really make out if his pupil is round or not. Might be a little teardrop shape, which could complicate management because I'm not sure if I would have tried to measure pressures on a patient with a suspected globe rupture. But
It wasn't.
sorry,
It wasn't a globe rupture. There
was
was
no globe rupture. Okay.
there was no globe injury.
And then he also looks like he has some flattening of the nasal bridge, and maybe some telecanthus. Could just be, racial variation, but I would also be suspicious for a possible NOE fracture in this patient.
So what would be so visual acuity was fine, that was not a problem. There was no step deformity in the rest of these skeletal bones, except for the fact that are you concerned about this eye?
Yeah, certainly. I am still concerned. I would also put it in an urgent ophthalmology consultation. I'd want them to come see him as soon as possible. And then I would repeat the checks like I discussed. Yeah.
Fair enough. So you've been trying to do that. You've tried to assess the extraocular range of movement, and he had some restricted eye movement in the upward gaze.
Yeah.
Be happening here.
I mean, this is a challenging question. I think I know where you're going. If the retrobulbar hematoma was sufficient, that might be impeding his extraocular movements, but I would probably sedate the patient and perform a forced duction test to rule out entrapment of the extraocular muscles.
Okay, fair enough. So, and how do you do a force duction test?
So again, I would sedate the patient to make him comfortable. I would topicalize the eye with tetracaine eye drops. I would then have an assistant retract the lids, similar to what's shown. I would grab kind of in the scleral region just below the limbus.
Anything else clinically that the patient can tell you while you're doing some procedures on this patient that
I guess you could ask if his eye was moving right after the injury. That wouldn't completely rule it out.
any pain in upward movement would also give you some clues?
That would also help, I guess. Yeah, although the retrobulbar is a confounding factor.
Just remove the retrobor for now, right?
Okay. Then I would
Cool.
ask about pain on movement. Yeah.
Okay, so this is the case, the same patient's scans here. What do you see?
Okay. I think it's a larger fracture now than I think what it was before, but this patient has a very large orbital floor defect, no medial wall defect, with definitely herniation of the orbital contents into the maxillary sinus. Uh, on the good soft tissue view, it actually does look like the inferior rectus might be entrapped around that bony fragment. So that is concerning to me.
And what's the safe period for it to be operated?
Pardon me?
What is the safe time for these patients to be taken to the OR?
So I think a patient with a true extraocular muscle entrapment should be treated within 24 hours to avoid necrosis of that muscle.
Yeah, that's great. I mean, 12 to 20, 24 hours, I would say. What is ocular cardiac reflex?
Yeah, so ocular cardiac reflex is a vagal response. So it's due to pressure on the globe that travels through the trigeminal nerve and then relays with the vagal nerve to the SA node, which can cause profound bradycardia and asystole.
Right. Have you heard the term white eye syndrome? And what is it? And which age group you would see this?
Um, a white eye syndrome, I think, is when there's a true entrapment, likely due to a trap door entrapment, usually in a young patient.
And what signs and symptoms they would have?
So they would have profound pain on extraocular movements, nausea and vomiting symptoms. Yeah, that's what I know.
What are the surgical, very good. What are the surgical landmarks on a medial orbital wall?
I think the classical surgical landmarks described are the anterior and posterior ethmoid arteries and the optic canal with
How
the
far, and how far they are from the anterior lacrimal crest?
so it's a 24-12-6 rule. So 24 to anterior and then 12 more, so 36 the posterior, and then 6 more,
That's
so
great.
42 to the
So
optic.
describe your surgical access approach to this patient in particular.
Yeah, there's several different approaches you can use. We're gonna do an orbital floor recon. So you're gonna uh, choose. You can do a subciliary or a subtarsal. I'm more familiar with a transconjunctival approach at this time in my training, so I would do that. So I would retract the lower lid. I would identify kind of sometimes there's like a vascular line that you can find that's nice to follow. I would incise through that with needle point electrocautery after injecting local anesthetic. This is being done in the operating room, of course, with the patient under general anesthetic and a corneal shield placed. I would dissect through that, and then I would use tenotomy scissors to dissect down to the orbital periosteum, making sure not to perforate it to expose your fat pads, infraorbital fat pads. I would then incise sharply through the periosteum and elevate it superiorly, dissecting into the orbital floor. I would try and trace back and identify my infraorbital nerve, although damage to this is possible and not catastrophic in these cases. I would still like to try and dissect it off. I would dissect from known to unknown. So for this patient, I would start on the lateral orbit, dissecting posteriorly. I would then elevate the contents up out of the sinus as discussed, and then find my medial landmarks before adapting my plate and placing my plate and securing it to the inferior orbital rim.
So what type of orbital implant will you use and why?
I'm most familiar with just titanium mesh. They also have good titanium mesh with MedPort coverings. Haven't had as much experience, but I've heard they're quite good. But I would just use a titanium mesh. That's what I'm familiar with. It's good because it is radio opaque, so you can assess the um,
So
uh,
you have placed the orbital floor uh, reconstruction plate mesh there. What next would you do now?
I would do a forced suction test prior to waking up the patient, and then some form of closure, just very loose, tension-free closure of my incision to prevent any entropion.
What would be your post-op instructions?
Yep. So I would do like some form of steroid antibiotic eye drop, so like a Ciprodex eye drop. I would want visual acuity checks, Q1H for the first 8 hours, and then maybe Q4H for the next 24. I'd probably get a post-op CT as well, just to ensure proper adaptation of the plate. And with my visual acuity checks, I'd also want extraocular movements checked by the nursing team. Head to bed elevation as well.
What is the most common complication while doing after the transconjunctival incisions?
Um, I think the most common complication I've seen or I can think of is entropion.
And then how do you manage that?
It's challenging. I haven't
Very
seen
challenging.
haven't seen a lot. I'd probably discuss with some oculoplastics colleagues. I know you can do different like grafting to correct it. I've heard you talk about like a
What would you do conservatively, and then what would you say?
okay. Yeah. So to try and release the scar tissue, I would recommend like diligent and frequent massage of the scar by the patient. If that doesn't correct it in 3 months, then I would pursue surgical options.
What options do you have?
So scar release, just basic scar release, although it's likely to just scar again and continue if you don't graft it with something. So some form of grafting, like a connective tissue or alloderm. I'm not super familiar with all the options, but I know I've heard of like even like gingival grafts being used. I don't know if you can use skin grafts.
No, so you can use a buccal mucosal graft. You can do a free gingival graft as we do it from the palate. That's probably the best one to do.
Okay.
No, it's all good. And you have to, are you, what is the frost suture?
Yeah, frost suture is a suture placed through the lower eyelid and then secured to the forehead to try and basically extend that incision line so it heals um, like flat and strung out to prevent contracture, which could lead to entropion.
So would that be a good option to do?
I would do it for all my cases for a transconjunctival.
And how long would you keep it there?
I think like 3 to 5 days is probably sufficient.
What would you let your patients know how to manage it? I mean, you
I
usually,
would let them know to not try and like over zealously open their eye, like just to keep it rested,
usually you have that string over, you can
eh,
actually, you don't
not to
have
play with the string.
to hide, yeah. You
Yeah.
actually put the tape over it, ask them to op and put it back again if they want to do it. I mean,
Okay.
most time, yeah, that's a good way to do that. What do you want to see in this case? This is the same case. The post.
Okay. Yeah, I mean, I'm looking for good adaptation of the plate, which I think I see here. I see the posterior aspect of the plate well within the confines of the orbit, sitting on the perpendicular plate of the palatine bone. I see it secured well to the infraorbital rim. It has that lazy S curve, which I think is recommended. That's kind of the goal, to have good orbital volume restoration. No entrapment of the extraocular muscles. That would have been confirmed clinically as well. So I think this looks pretty good to me.
Okay, all right, that's all good. Thank you very much, Derek. You did very well.
Thanks, Dr. Shah.
But, just go over it again, and but I think you got all the answers correct. Um,
I know how you think a bit, so I have a bit of an unfair advantage. Yeah.
that's a bias. I'm sorry, folks, but that's a bias there.
Yeah. All right.
That's,
Thanks, Dr. Shah.
thank you very much. Well done. Okay. Third case, who's there to take that? Do we have the folks here? Jihoon is done, and then Derek is done. Who else is here? I can't hear you.
I don't think we have any other chief residents who has
Okay.
joined today. So if you want to pick someone, that would be great.
You should. Are you a third year resident or?
Yeah, and third year.
Oh, you should be good. You should be good. Let's do it.
Freddie, why don't you and Amber and a few other of the
Yeah, both of them. Both of
second
them
to
can do
last
it.
years do it together?
Yeah, sure. I would
Yes.
love if Amir would join me.
I hope this is not very tough, is it? Is that okay?
No,
for
it's
you?
really good actually.
No, it's really
great.
good. Yeah.
We do a lot of trauma, so that's why we have all these cases collected over the years. Okay, so our third case is both for Freddie and Amber. So that's the case.
So the case is like you got a call to ED to assess a 26-year-old male with multi-system trauma, including suspected facial fractures following a head-on collision while driving intoxicated. Per report, patient was opening his eyes to painful stimuli, was making incomprehensible sounds, and was withdrawing to painful stimuli, not localizing pain. Patient was intubated orally by EMS and just arrived to ED.
So my question is, what was the patient's GCS score in the field before intubation?
So opening his eye to painful stimuli, I guess that would be 2 for the eye.
Mhm.
Withdrawing from incomprehensible sounds. That would be also like 2, if I'm not wrong.
You're right. Yeah.
And with regards to withdrawing of painful stimuli,
3.
3
4
or 4.
and total paid. Good. Well done.
Yeah, so 8, GCS 8,
That's good. What are the indications of intubation in a trauma patient?
and GCS of 8, intubate.
What else?
When the patient is not able to secure his airway, and there are chances that patient is going to become more unconscious.
Why would that happen in a facial trauma case? Apart from
Because of the chances of head injury or the brain injury. So
apart from brain injury, that's what I'm saying. Apart from brain injury, what will be an issue for airway management there?
any foreign body in the airway, mandible fractures, so the tongue falling back, causing asphyxia.
Unstable mandible and maxillary fractures, right? What else? Uncontrolled bleeding.
Yeah, uncontrolled bleeding, foreign bodies in the airway.
Absolutely. All of this, right? Good. You're asked as a primary trauma surgeon there, called to the site. Describe your initial assessment here in this patient.
So to begin with, steps for ATLS, first airway, make sure that the airway has been secured, then make sure if the patient has equal breath sounds bilaterally, so breathing is good, and then rule out any other bleeding issues, especially from the main areas, from the head, from the chest cavity, pelvic cavity, long bones, or on the floor. So once ABCD and definitely the GCS as well. Once they are managed, I think you can go to more focused maxillofacial assessment.
Define shock.
So in my opinion, shock is like decreased perfusion of the end organs and the organs not getting enough blood supply and the oxygen which is needed.
Okay, what are the four main types of shock?
So we have hemorrhagic shock, we have distributive shock, cardiogenic shock, and septic shock.
Yeah, obstructive.
Obstructive, yeah.
What is the common type of shock in trauma patients?
Hemorrhagic shock.
Yeah, or hypovolemic, right?
Hypovolemic. Yeah.
How would you differentiate between a hypovolemic shock and a neurogenic shock in the initial stages?
So usually in a hypovolemic shock, looking at the vital signs, like patient will be like tachycardic with decreased blood pressure, more leaning towards the hypovolemic shock.
Thank you. And then for the other one?
Both tachycardic and bradycardic, like hypotensive and bradycardic.
That's very good. That's very good. What degree of patient blood volume can be lost until an adult patient demonstrates a drop in blood pressure?
I guess around
Well, how much blood should
15 to 30%.
about 30%? Can you give me the classification of various blood loss hemorrhagic shock?
So depending upon the volume of blood loss, it can be like less than 15%, 15 to 30, 30 to 40, and greater than 40%.
What are the what are the main areas quoted to have bleeding that can result in hemorrhagic shock?
Sorry, can you repeat that question?
So what are the commonly quoted areas of bleeding on the body
Yeah.
can result in hemorrhagic shock? So you would have fracture of this.
Yeah. So any trauma to the chest, trauma to the pelvis, trauma to the long bones,
Very good.
abdominal trauma.
Very good. Very good. That is perfect. Let's go to the next one. So we have given this to the same patient. How would you measure to determine the patient has been adequately fluid resuscitated?
Patient is vitally stable now.
Yeah, it is stable, but what will be your criteria that you have given enough fluids, patient has been fully resuscitated?
I can phone a friend Amir over here.
Yeah, so things I would look for in this case, from a vital standpoint, is I'd be looking at their blood pressure, looking at their heart rate. If I'm measuring their urine output, that's something that I would be looking at as well, ensuring they have adequate urine output.
That's beautiful. Okay, let's describe this fracture pattern. Let's see this first again. Describe your assessment of facial fracture here.
So what you're seeing over here is a 3D reconstructed view of the CT scan. Just looking at the frontal region from the front, I can see that the patient has can be classed as a panfacial trauma. Coming from bottom up in the mandible, patient has a parasymphysis fracture on the left-hand side.
So, Freddie, before that, how would you assess the soft tissue? What would be assessment for soft tissue as well? You're looking for some laceration.
So I'm looking for signs like periorbital edema, ecchymosis, raccoon signs, moon face, shape of the face, any lacerations, abrasions on the initial inspection.
What is bowstring?
So bowstring test is to rule out if the patient has any naso-orbitothumeral complex fracture. So if you pull on the lateral surface of the sides, and if when the canthal detachment is there, you can determine with the help of that test.
And what is a battle sign?
Battle sign is whenever there is a skull base fracture in the mastoid region behind the ears, there is an ecchymosis over there, mostly indicating of a mastoid fracture.
Okay, so describe the facial fractures patterns here on this.
So looking at this 3D reconstructed view from the front, from the bottom up in the mandible, I can see there is a left parasymphysis fracture. And on the midface region, I can see that the patient is having like a Leaford 2 type pattern fracture, which is like a pyramidal structure extending from the nasal bone, tracking down towards the inferior orbital rim and going down towards the pterygoid plates on the either side.
Okay, so you will classify these fractures as?
A Leaford 2 fracture.
Just a Leaford 2?
With mandibles, a panfacial.
It is a panfacial, yeah, but do you see anything else? Any zygomatic bone fracture or?
Yeah, there is a zygomatic bone fracture as well on the left-hand side.
A Leaford 1 fracture too?
Yeah, Leaford 1 fracture too.
All right. So patient remains intubated and sedated in surgical ICU. He's nearly to be extubated. What are your criteria for extubation in a normal patient without facial trauma?
So when the patient has like a pass a spontaneous breathing test, and when there is a cuff leak,
Mhm.
those are some of the criterias which we can be determined if the patient can be safely extubated, because then they'll be able to maintain their airway patently by themselves.
Do you think this extubation criteria applies to this patient?
Not really, because in this case, like if the lower mandible and the junior glossal muscles are not stabilized, then the patient can asphyxiate by the pushback of the tongue.
And what else? If one is mandible, what else? It could be a problem.
Even the mid-face fractures,
And this was
yeah, that can also cause obstruction of the airway.
it was floating.
Yeah.
Anything else that you look in this patient that could be an issue?
With terms of airway,
Yes. Or compromise to an airway. Do you see these teeth here?
yeah, loose, fragile teeth, which can be a very high risk for aspiration.
Yeah. Okay, that's important. Don't forget that, right?
Yeah.
Okay, so describe your surgical plan from start to finish, including airway management in this case.
So we'll keep the patient intubated. We'll try to arrange for an operating room. Try to take the patient to the OR and think
Knowing that
of.
he had an oral tube.
Yeah, so I would convert that into a submental intubation at the time of the operating room,
How do
because
we-
so submental intubation, I would ask for an oral ray tube with the anesthesiologist. And then at the beginning of the procedure, we'll discuss about submental intubation, and then you can give incision just at the lateral side of the lower border of the mandible in the area of premolar region. Give a cuticular incision, do a blunt dissection, dissecting up to the floor of the mouth. Then, when at the time of exchange, get one distal end of the oral tube through the floor of the mouth, passing cutaneously outside, and then reconnecting the tube.
Okay. Now your surgical plan.
Surgical plan for this patient, again, I would go like top-down approach, and from like, because I guess it's more stable to more unstable segments, as there is no much frontal bone fracture over here, so the frontal area is quite stabilized, and from outside towards inwards. So I would first try to do an open reduction and fixation of the left zygomatic bone fracture in order to get the volume, lateral volume of the face. Then I would try to fix the Leaford 2 fractures. So definitely there will be multiple approaches, extraoral as well as intraoral approaches. So open up all the wounds, expose all the fractured segments first. Intraorally, I would open up like a Leaford style incision. Um, then starting with the fixation first of the left zygomatic comaxillary complex fracture, then coming to the Leaford 2 fracture, then intraorally on the pyramids of the bony buttresses of the maxilla, I would try to plate at the pyriform as well as at the zygomatic comaxillary and pterygoid region. Once the midface is stabilized, then I would put the patient into MMF, get him into the occlusion, and try to fixate the parasymphysis fracture.
Amar, would you do the same way?
I think depends on your philosophy. I think for me, what I would do is I actually would start in the mandible in this case, because I feel the mandible is a bit more, it's less comminuted, simple fracture in that respect. As long as you're pressing on the angles and you're making sure that the inferior border lines up so that you're not almost like green sticking the mandible out. And once you've obtained a stable mandible, then I would build the rest of the occlusion off of a stable mandible.
Mhm.
So I'd start from bottom up in this case, personally.
Jihun?
Yeah, I agree with Amar. I think I would go from like more simple to complex and do the mandible, um, and then go from like outside in and then do the the maxilla Lefort one last.
So when would you treat this fracture?
So that would be I would do the mandible, then go from the zygoma, and then build like my lateral buttresses, and then come in and do the medial NOE component. And then once that's all reduced, then I would fixate the maxilla Lefort one, just because that has more give to all the different like minor changes if you
Just
can't get perfect reduction.
you want to answer this?
Sorry?
Justin, I'm asking Justin if Justin's available.
Oh, Justin.
Oh,
I name.
I would do kind of the same approach, like mandible first, because you have like the renal height and everything, and then establish your occlusion, and then I would similarly go into the NOE complex area as well as the zygoma, and then fixate the Laporte last as well.
Very good. That's the way to do that. Absolutely wonderful. How would you access the NOE fracture here? Derek, you want to comment anything on the steps that they've just spoken? Justin was very right on them.
Yeah, I think they did an excellent job. I know the case, so I know the answer a bit, but I
So
think I would.
how would you access NOE fracture here?
Yeah, I mean, it's not a significantly displaced NOE fracture.
Not you, Derek. I'm gonna.
Okay, sorry.
So just give me the axis of all the fractures that you want to do. We know the intraoral ones, right? But just talk about the extraoral ones. So there is a right ZMC fracture at the frontozygomatic. There's an NOE fracture. There are infraorbital fractures, both right and left. You can see that. How would you access all these fractures? The bilateral NOE, bilateral infraorbital rims, and unilateral right frontozygomatic suture.
Do a coronal incision for the NOE fracture unless it is like pre-existing laceration. But then
Right. There was a pre-existing laceration too, but that was very small. But you could there. You're right. So you will do a coronal incision for that, right? Any other incisions that you can use for it?
for the infraorbital rims, I would consider doing like either infraorbital, like if there's already a crease or subtarsal conjunctival approaches.
And for your FZ suture or
Yeah,
right side?
sorry, for the FZ suture,
Yeah, I mean, this was fractured too here, but it doesn't show here.
the coronal approach,
Would help, right?
you know,
Anybody else who wants to do some local incisions?
I mean, if there was a significantly displaced NOE or FZ, I would certainly agree without doing a coronal. In this case, I don't know if it's like significantly displaced enough for me to proceed in that direction personally. I feel a lateral supraorbital rim incision would be enough to approach the right ZF. And then for an NOE, you can do just a localized incision just right over where the fracture is located, kind of thing, like a not quite a Lynch or Galwing, but something similar to that.
Do you describe, very nice, this is a good answer, but do you know the accesses to the NOE local incisions? Can you give me a few names?
Yeah, there's like the Galwing, Lynch. I mean, there's a few of them, but yeah, Galwing and the Lynch are the ones that I know.
Very nice. So what we did here was, Derek, you want to explain?
Yeah, sure. So yeah, we made the decision that due to the patient's hairline and the non-displaced nature of the fractures that we could likely plate these with extremely small and conspicuous incisions. So for the right ZF, we did a kind of modified upper bleph incision, which is very well hidden in a crease. And then we kind of extended a very small laceration over the left NOE, kind of just under the brow, and then did a similar incision on the right side. And the patient healed with almost imperceptible scars. For the inferior orbital rims, we did a subciliar approach, a nice crease. And again, he has almost imperceptible scars.
So this is what we achieved in as you can see, very minimal, very small incisions here, as Amber said, right? And you can hardly see them now. So we just modified our incision lines, right? So the problem is if you want to give some lynch incision here, there's lots of webbing here. You can go across with the glabellar incision. It's a very unsightly incision too, right? And this was an upper left that Derek was mentioning. So we did very limited incisions. And you said very rightly, because it was not very displaced, so there was no need to do a coronal incision on this patient, and there was no frontal bone involved either, right? And the patient had a concern that he was already receding hairline, so he wasn't very happy with any of those major incisions. But that's fine too. You can certainly do that. But I think rationale here was to give some local incisions which could be hidden, and that's the way we did it. Any questions? And thank you and good luck.
Thanks, Dr. Shah.
Thank you very much, Dr. Shah.
Just like for my knowledge, like why bottom up is more better than the top down for this case?
That's well, to be honest, once you are doing your plating, it really hardly matters which way you want to do. But if you do the mandible first, you are fixing your frame that you're basing your mid face on it. And so we will always do that because you want to have an AP projection of the mandible properly, so that you fix your maxilla on it as an interim MMF, and then you go outside and fix everything here, and then come back into the oral cavity and fix your leaf fort, 1 or 2 fraction.
Yeah, I think just to clarify, Freddie, it still was like a top down, outside in, just plating the mandible separately first because it was anatomically reduced. And I would also make the point that, if you fixate the mandible with a stable base, then you lock the patient into IMF at the start of the case. So the bite's going to be good. And then start at the top. And then, like several people mentioned, fixating the maxilla last because you have the most wiggle room there. Seemed to give this patient a good result.
We always do our mandibles first, and we always restore the vertical and AP projection of the mandible, bring our maxilla on top of that, and leave it there, and then go back outside and then start from the outside, and actually converge like that. You're right, zygomatic bone, FZ sutures, frontal bone, right? And then we go to NOE, infraorbital, and lastly we do the nose. And then we come back again into oral cavity and then fix our leaf fort, 1 or 2 fracture, whatever that is.
Also, I'll just mention, I don't know if it was talked about at the start, but this patient was not extubatable post-op. So we did a trach. We got a trach done for us because converting him back, you can't go to ICU with a submental, obviously. So leaving this patient, with a TBI with an oral tube post this recon is not a feasible option. So definitely was an indication for a trach. Yeah.
Okay, that's what we did, yeah.
Yeah.
Was he not extubatable for localized edema around the airway or due to his traumatic brain injury?
TBI was the reason for that.
Yeah, he was close, but they were concerned, like he was close to extubatable kind of the day or two before, but anesthesia and ICU rightfully, I think we all agreed that after this fixation, he was going to be wired shut. So they didn't want to extubate him in the OR without a secured airway. Yeah.
Fair enough. Okay, thanks.
Any other questions? I think that was a good session, man.
That was really good. Thank you so much, Dr. Shah. I really appreciate your time.
This is what they will be asking this. There won't be anything more than that on trauma. They certainly cannot be, right. This is everything I'm expecting to know. But just go through the basics. Do learn some of the basics. We tend to forget that at times. Just go back. And then, Freddie, it's important that you keep the sequence on. I mean, if you have one sequence, that's what the examiners are looking for, right? And G,
Perfect.
just review some of the basic stuff that you have to, right? Derek will revise his steps again. All right, thank you very much. Was it, he's still there?
Okay.
Thank you so
Awesome.
much, Dr. Shah. That was really great. I'll
Thank
just
you.
stop the recording over here.
Thanks very much.